Okay. So, our very first lecture, we mostly focused on Chapter 1, which is really sort of an overview of epidemiology. And what we really did was focus in on the definition of epidemiology, which was, remember, the study of the distribution and determinants of health-related states or events in specified populations. And then finally, the application of that study to control the health problems, right? There should be some benefit of the study. So remember, the example that I used for health-related states or events was cholera, and that was in a specified population in Haiti, right? And that was immediately after, or a few months after, a large earthquake in Haiti. And remember, we talked about how we could describe the cholera outbreak spatially throughout the country of Haiti, but we could also look at it versus time as well, see, to get more information about perhaps how it is spreading over time and how it might be transmitted. We also talked about determinants of that particular health-related event or state or disease, right? So that's really anything that's a cause or could be linked to a cause, associated with a cause of that particular disease, in this case, cholera. So the most important determinant is the bacterial pathogen, the germ that causes cholera, and that's Vibrio cholerae, right? But there's other determinants as well. For example, not having access to clean, potable water, right? So that a person would have to drink from contaminated water that could possibly have, remember, these organisms that carry that particular type of bacteria, right? Any questions before I go on? Okay. So from there, we went on to talk about really some of the basics in terms of terminology of disease and epidemiology. And that was the subject of Chapter 2. And in that, we used the example of a recent Salmonella outbreak. This is showing the, I'm going to go ahead and turn the lights so you can see a little bit better. All right. This image is showing the spatial distribution of the outbreak. And remember, I mentioned that it had been linked to a particular distribution center for papayas in Southern California, right? And we do see the most events happening in California. So one of the things that you should be familiar with going to exam are what are the different ways that infectious agents can be transmitted? And then using this information that I give you, think about, well, how might Salmonella be transmitted in this case, right? So what I'd like for you to do actually right now is take 2 minutes, converse with a partner, and jot down some ideas for the answers to 1 and 2 here. All right. Great. So then, let's go ahead and start with number 1. What are the different ways that we talked about in this class that infectious agents can be transmitted? Yes. Jeff.
Like through vehicle. Correct?
Vehicle, yes. Vehicle transmission. And that's in your book. They called it common source transmission. Yeah. And by the way, you can treat those terms essentially interchangeably, right? In this case, actually, if we want to skip to number 2 real quick, what is the mode of transmission for Salmonella in this case? The vehicle transmission. Yeah. What is the vehicle in this case? What's carrying the Salmonella? Yes. Papayas. Yeah. Perfect. So what are some other, flipping back to 1, what are some other ways that infectious agents can be transmitted that we talked about in this class? Yeah. Let's see. Zulema first, and then Alessia.
Contact transmission?
Yeah, contact. So there is direct contact transmission. All right. And another term for this was person-to-person transmission. That's what they talked about in your book. Now, direct contact transmission can also involve something called droplet transmission. All right, that's still an example of person-to-person transmission. That's where someone literally coughs or sneezes, or there's some sort of spittle fluid coming from person A that has the infection. That spittle has the pathogen in it and lands on somebody else right next to them, right? Droplet transmission. So yeah, this includes droplet transmission. Yeah, that comes under direct transmission. Sorry, droplet transmission comes under direct transmission, person to person. Yeah. Indirect transmission also came under that as well. That's the case where maybe someone maybe coughs on their hand, touches an inanimate object, and someone else nearby comes in and touches it, and then touches some sort of portal of entry on their body, their mouth, their nose, their eye, for example, right, and get sick. All right, there was a third mode of transmission that they didn't talk about in your book, but we did talk about in this class. Does anyone remember? Vector transmission, yeah. Right, and what is vector transmission? Yes, so there's some sort of animal, generally some sort of bug, that carries the pathogen, and upon biting different hosts, transmits the pathogen from host to host, right? So there's something actually alive carrying the pathogen from person to person. Great. Any questions about this? Yes?
So can direct contact and person actually be used interchangeably? And then droplet and indirect go under direct contact?
Oh, great question. That's the best way to think about it. Because contact transmission, right, and direct, droplet, indirect all come under that. Great question. All right, yes, Chris.
In this example, the papayas were it was vehicle transmission.
Yes, yes.
But these scenarios get complex. Like, for example, let's say one person he's just distributing papayas and he's just coughing on them and handing them out one by one.
So that's an example of where it could really be both, right? Yeah, so first of all, it's indirect transmission, right? If he's getting something on an object and it's transmitting, but it's also common source because he's producing a whole source of vehicles that are all contaminated, right? So in that case, it's both. Fantastic question. Great. Good. All right. So these are sort of things that you should be familiar with going into the exam. All right. We went in to talk a little bit about the difference between clinical and inapparent cases. And that to remind you that really all the cases of a disease that you see in the clinic are generally just a tip of the iceberg in the population, that there's probably many more people who've been infected that either A, don't know about it, or for some reason it's the clinical presentation, the symptoms are not bad enough to get them into the clinic, right? So that would be examples of subclinical, right? And we talked about different examples, also persistent infection. There's certain types of Salmonella that can persistently grow inside the host without causing disease. There can be examples of latent infection. That's where the pathogen remains in the host, is not replicated. The example that I used in this class was herpes simplex virus 1. the virus that causes cold sores, right? When those cold sores are not erupting, then that person is still latently affected, but the virus is not replicating. All right. There's also preclinical period, right? The period before symptoms start to show up. This is often called the incubation period of a disease. And the issue to remember here, and this is going to depend upon particular infectious agents and particular diseases, but these the people in these cases can be be reservoirs for the pathogen and could possibly transmit the pathogen. All right, so they are of concern for those of us who are trying to control a particular disease in a population, right, from it growing and spreading. Yeah.
What was the incubation period again?
Oh, so actually that was shown in this figure taken from your text right here. So incubation period is the period it takes for the pathogen, once it gets into the host, to really sort of get a foothold in the host, replicate to the point where it actually starts to cause symptoms. The person actually knows that they're infected. They know that they're sick. Right? And it can really range from infectious agent to infectious agent. That's what this is showing, although it's covered up with this block right here. But I just want to point out poliomyelitis, right? Or polio, as we know it. Look, this is actually the range in days of its incubation period. It can range up to 3 weeks. And that's an issue because during those 3 weeks, people who are infected with the polio virus can actually transmit it and spread it. So then the question is, how can transmission of these diseases between inapparent cases, especially if they are infectious diseases caused by infectious agents, how can that be prevented in a population at large? And there's many different answers to that. But one example that I gave that applies to polio is vaccination. Right? So that's just one example. Right? Remember, vaccination is simply where someone is given, or people in a population are given, a weakened or killed form of the pathogen, right? Often by injection, but sometimes through ingestion, depends upon the vaccine, right? The person's immune system reacts to that weakened or killed form, right? Induces immune cells that have adapted that can fight off that pathogen, so that when those people are then confronted with the real thing, the real germ, the real polio virus, then they already have immune cells that will recognize it and can kill it before it can actually grow and cause symptoms in the new person. Any questions about that before we go on? Okay. Oh, yeah.
So, for example, the flu shot,
Mm-hmm.
when the flu shot, is it always the same shot, or is it a little different?
That's a great question. And it differs from year to year. So generally the flu shot, it's always a piece of the flu virus, and it's a piece of the flu virus that we know our immune system has a good job, can do generally a good job of recognizing and forming immune cells that can fight off that particular piece. So it's the kill virus. It's the kill virus. Now, that particular piece varies from year to year. The reason for this, the flu virus is highly mutable. It's mutating all the time. The polymerase that replicates its genetic material makes mistakes all the time. And so that's good for the virus, because that means that populations, every time it changes, the population has access to populations that are no longer immune to it anymore. So as the flu progresses in other parts of the world, generally in the southern hemisphere, people in the northern hemisphere track those flus, those new flu viruses, try to see what's the most prevalent. It is a bit of a guessing game, though. All right? They try to find out which flu viruses are the most prevalent, and they take those particular strains and kill them, take those pieces that they know are good for forming a vaccine of those viruses and puts that into the vaccine. All right. Now, from year to year, sometimes there's big changes and sometimes there aren't. I believe the flu vaccine actually did not change this year from last year. So the flu viruses that were supposedly prevalent the year before are prevalent this year as well, right? And we're finding that we don't know for sure yet because we can't really tell until we get to the end of the flu season, but it's looking like also the rate at which this vaccine is protecting the population is about the same as it was last year as well. Yeah, that's a great question. Yes.
Wasn't the outbreak of the flu this year worse?
Much worse. It has been much worse.
Doesn't it go like 4,000 people?
Yeah, I don't know what the numbers are as of today, but yeah, they've been actually asked quite high. It's comparable to the 2009 swine flu epidemic, where they had quite high numbers of deaths and numbers of people. Yeah, so I know it's puzzling at this point. We're getting numbers saying, well, it's protecting about just as well, but we're seeing so many more people, and we don't know the answers as to why that is yet. We need to have better numbers. A, how many of the people who got the flu were actually vaccinated, and how much of the population overall was vaccinated. And then only once we have those numbers after the epidemic has ended, right? Hopefully sometime in the spring, we'll get those new numbers out. Yeah, we might find that it's gone down, but so far they're reporting that it looks like it's the same. Yeah, good question though. Good question. Right. Luckily though, in California it seems to have peaked. Right, the peak of the flu epidemic has passed. Yeah. All right. Okay, any other questions about vaccines before we go on? Okay, great. So, remember we also talked about how we can look at the distribution of a disease over time, right? So, we could take a look at the number of cases, and if those cases over time are all about the same level, maybe sporadically going up or down, but average stays about the same, we call that endemic, right? So that means that disease is always present in a population, right? And that's important to know because if it is endemic, if we see a case, that's not really cause for alarm for the population at large. However, if cases all of a sudden to shoot up, right, so they're many more times what you would expect, then we refer to that as an epidemic. Right? So here's the issue though. What if in this population, all of a sudden, for some reason, say this is town A, their population increased 3 times, right? Yeah, well then, oops, sorry about that. I don't know how to get rid of that. All right, sorry about that. Okay, so back to the issue of population changes. So the way to account for that is to then take the number of cases that occur and divide that by the number of people in the population during that time, right? And that's called calculating the attack rate. Right? And that was one of the first measures of morbidity that we did in this class. So I'd like to just review the example that I used in this class and give you a chance to go through the calculations one more time. Just a couple of minutes. Just a couple of minutes. So remember, this case was taken from a norovirus outbreak on a cruise ship, right? So remember, there were 2,882 passengers and 944 crew members. So together, these make the total population on the ship, right? And then I'm asking you to calculate the attack rate as of October 28th. So that's this day right here, right? And by the way, what we can see here is that there's probably about, I would say, 74 people, according to this graph, on October 28th with norovirus infection. Once you had a chance to calculate that, think about whether or not you would consider this outbreak based on this graph, and what type of transmission is most likely causing this outbreak, if it is one. So please go ahead and take 2 minutes with a partner with those calculations. I'll come around for questions. We'll go over it in just a second. So let's go ahead and start with attack rates. So first of all, how many of you calculated this as attack rate per 1,000 people? All right, so what would that be?
I got
19?
19.
Per person.
Yeah, for everyone.
All right, fantastic. How many of you did it per 100,000 people? Good. Actually, it makes a lot more sense to do it per 1,000, right? Because you don't have 100,000 people on the ship, right? So that makes a lot more sense, all right? That's fine. But if you want to do that, you would, again, is take that number, 74 or 73, whatever you estimated based on that graph, divide by the total number of passengers, and then multiply that by whatever number of persons you want to calculate that rate for. All right. How many of you calculate percent? All right, Freddie, what did you get?
Roughly 2%.
Yeah. Say 1.9%. Yes. Right? And then again, you would still take that fraction, 74 cases divided by the total population, right? And then multiply that by 100%. Any questions about that? Okay, great. Now let's go on. Would you consider this an outbreak?
Yes.
Yes. Why?
Because of the peak. Because we usually start off with nothing and then it jumps up to a peak and then can go down.
Right. So you start off, the key thing is you start off with no cases of norovirus infection, right? This was not something that was endemic in this population at all to begin with, right? And all of a sudden, it shot up, right, in one day. All right. And then it very quickly went back down, right? Looking very much like an epidemic. All right. So yeah, I would say an outbreak. Now, this question is a little bit more tricky. What type of transmission do you think is most likely, looking at the sharpness of this peak?
Could be common vehicle, could be the right.
What?
We just have to know whatever they give us.
Yeah, so I heard you say vehicle. I heard you say vehicle.
Wouldn't it be person to person? No, I don't know.
How come? Or why do you think vehicle?
Because a lot of people got it at the same time.
Yeah. So generally, common source epidemics or common source outbreaks have this very sharp peak associated with it. You have a whole bunch of people get it right at once because they're probably all exposed by some common source. Whereas for person-to-person transmission, they're epidemics, but they tend to takes a little bit longer to get going. So you would see something that would look more like this, right, for person to person. All right. Any questions about that before we go on? Yes.
How could a complex scenario be work in this situation?
Yeah, I mean, I don't want to digress too much, but you can have situations where, case in point is Ebola transmission. That's classically person to person, right? And generally, you see epidemics form, they have that sort of slow shape to them. But you have situations where there are funerals where a lot of people may have touched the person who is sick with Ebola all at once. And there you have something that's going from person to person, turning into something more looking like common source at that point, at least for the people at that funeral. So yeah, it can be more complex, absolutely. Yeah. Great. All right. So from there, we moved on to talking about more measures of morbidity, and then we also talked about measures of mortality. And those were the subjects of chapters 3 and 4, remember. And I used an example of breast cancer to talk about all these different measures, right? Now, on an exam situation, I won't necessarily have breast cancer as an example, but I would probably have another similar type of cancer to ask questions about, all right? But I wanted to use this example to help practice going through those calculations together. All right, so remember, I'm not going to go through this again for you, but we'll come back to that in just a second. All right, remember we talked a little bit about how the disease progresses, the natural history of disease. Remember we came back and that was really more the subject of chapter 6, but we had to talk a little bit about this at this stage as well. So remember, especially for a disease that progresses over a long period of time, it's important to think about. There are initial stages to the disease, the initial onset of the disease. And during that time, similar to the incubation period for an infectious disease, often generally there's no symptoms at that point, right? And a person can progress for a while not knowing that they have the disease until they have some kind of symptom. In case of breast cancer, a lump, for example, right? Yes?
So, on the exam, would you be necessarily looking for like initial cellular changes, noticeable change in them, or would it just be like disease onset symptoms, seek care, diagnosis, treatment? Like, are you looking for specifics or?
Oh, like on exam, would I be like asking you to name, the different stages, for example? Not necessarily. But in order to be able to think about other methods like screening, for example, which we're going to talk about next, you should be familiar with the stages. Yeah, I think that's important. Right. For example, that screening would happen about here. Oh, you can't see my cursor. Shoot. Sorry. So that screening should take place somewhere around here, right, before actual symptoms occur, right? But maybe there's something else that that would be noticeable, right? For example, something that blocks transmission of X-rays or a mammogram, right? All right. So we talked about several different measures of morbidity, right? So that measures of people with the disease. Okay. The first, probably one of the most important, is incidence, right? Because incidence is a really good estimate of risk, the risk of someone getting that disease in a particular population, right? And again, it's generally calculated as a rate per some number of persons or people, and I will specify that on an exam situation, right? So an example would be per 1,000 persons, but you could easily replace that with 100,000, right? Whichever makes the most sense. All right, and so to calculate the incidence, remember, it's the number of new cases occurring in a particular population during a specified period of time, right? Divided by the number of people in that population who are at risk of that disease during a specified time, during that period of time, all right? And then to contrast that, there's prevalence. Now, prevalence is not taking into account the number of new cases. It's taking a look at all the cases that exist in a population and dividing that by the total number of people at risk of that disease in that population. All right? So what I'd like you to do right now, before we go on, is just take a moment. I'll switch back to the numbers before. Take a moment to calculate incidence and prevalence. And then think about what's the difference between prevalence and incidence. All right, so I'm going to flip back now to the data on breast cancer for 2014. And please take a moment to calculate incidence and prevalence.
All the cases divided by
And for the sake of consistency, let's calculate per 1,000 persons. So as soon as somebody has a calculation for incidence, go ahead and raise your hand. All right, go ahead.
1.5 per 1,000.
Yeah, I got that as well. So to do that, remember we take 236,968. That's the number of new cases in 2014. Divide that by the total people at risk in the population. So for that, we're going to use the total number of women in the population, the U.S. population. Right, and that's 156 million approximately. Right, and so you take that fraction and multiply that by 1,000, you should have gotten of 1.5 about per 1,000 women. All right, so how about the prevalence now?
So prevalence is different from incidence just in that the numerators, the new and the old cases?
Essentially, yes.
Okay.
Yeah. So just what you said, the main difference, this is the answer to the last question, between prevalence and incidence is prevalence is taking into account all the cases that exist in a population during that time, right? So it could include people who got breast cancer prior to 2014, and most likely definitely does, because breast cancer is something that occurs over many years. Right? Can occur over many years before there's resolution of the disease. All right, good. So then what do you calculate for the prevalence? Let's take somebody else. Zulema?
Okay, I got 21. Okay, that's it. Okay.
21?
21.19.
Did everybody get something around there? Yeah. 21 per 1,000 women. Right.
So just to be clear, we don't have to add the newly diagnosed because that's already in the US women have breast cancer.
Exactly. If I'm telling you that 3,327,552 U.S. women had breast cancer in 2014, that includes this 236,968. Yeah, that includes these 236,000 women that were newly diagnosed during that year as well. Absolutely. Great. Okay. So remember, we also, since we're running a little bit short on time, I'm going to breeze through maybe the next parts a little bit quickly because I want to make sure we get to survival analysis before I let you go. By the way, I am happy to stay here after 12:15 to continue going through this. So if you would like to stay through a little bit of your lunch hour to talk more about this, I'm happy to do that with you, right? All right. So we talked about calculating mortality rate as well. Very similar to calculating some of the other rates that we talked about, except now we're talking about death, all right? So the mortality rate of breast cancer would be the number of deaths due to breast cancer divided by the number of people in that population. And because deaths change the population number, right, you would have to take the population at the midpoint of the year you're asking about, right? The midpoint of the duration of time you're asking about, right? And again, in this example, I'm asking you to calculate mortality rate per 100,000 persons. In that case, you just multiply by 100,000. Okay. So I'm going to skip over this for now, but we can come back. All right. I do want to say something about case fatality, though, because this is also a very useful measurement, right? So this is actually looking at, really, the likelihood of dying of a particular disease, given that you have the disease, all right? And it's often calculated as a percent. You'll generally see case fatality calculated as a percent, right? So if I'm asking for you to calculate case fatality, and I don't specify, okay, per 100,000 people or whatever, calculate it as a percent, right? So multiplying the number of people dying of a particular disease divided by the total number of people with the disease multiplied by 100%. Okay. So I wanted to bring back that last table in the paper that we discussed because it really brought in a lot of these calculations that we've just talked about. And I think it's helpful to look at this paper as a way to test ourselves if we understand truly what incidence and case fatality is actually talking about. Okay, so remember in Welch et al., they were able to calculate the case fatality rate for breast cancers, in which case the tumors were greater than 5 centimeters, between 3 centimeters and 4.9 centimeters, and between 2 and 2.9 centimeters, right? And they were able to calculate the case fatality rate back before mammography, as well as after mammography had been instated, so over a 30-year period from the 1970s to the 2000s. And their point was, for doing this, was that, well, actually, mammography didn't really help with uncovering any large tumors to begin with, right? So we can see that any improvement in case fatality, right, percentages as they go down, really has to do with improved treatments. So what they did here is they actually took the difference in the case fatality rate for each of these different tumor sizes, right? And by the way, this 12 really should be 12% written here. They then multiplied that 12% by the incidence of these different tumors, right? They're actually able to calculate the incidence of these tumors per 100,000 women, right? 29, 56, 60, right? And this was the incidence in the 1970s. They multiplied that case fatality rate difference, right, by these numbers to get the mortality reduction, right? These are the number of lives saved, essentially, or the reduced number of deaths per 100,000 women according to each tumor size of each of these large tumors. And they are able to add those up to get the overall numbers of lives saved per 100,000 women. And that's this 17 value. All right, question?
So in terms of regarding to the exam, how would you be asking us to analyze the graph?
So overall, so in cases of case fatality, are you asking specifically about case fatality? Because for case fatality, I might give you different numbers to calculate case fatality, right? I didn't give you a chance to do that now, but for example, if we were to go back to this data, you should be able to take this data in order to calculate case fatality, right? And how might you do that? Right? Yeah, so yeah, why don't we, since we asked the question, why don't we go ahead and do that? So let's go ahead and take 1 minute to calculate case fatality of breast cancer. So I'm going to go ahead and flip back now to the numbers. All right. So who would like to take me through their calculations? Chris.
I took the number of women who died
Yes,
of
good.
breast cancer and divided it by the number of women who were diagnosed with breast cancer. So we divided by.
It'll be all multiplied by 100% over here.
Yeah.
And then, what did you choose to have as your denominator?
The women who were diagnosed with breast cancer. The women who had breast cancer.
Yeah, so this is tricky. So what you're going to use as the denominator, right? Should it be the prevalence or should it be the incidence in this case? So really, if it's truly all the people who have breast cancer, right, it really should be the prevalence. Right? So that would be, I'm sorry, I don't mean prevalence, I mean the total number of people with breast cancer. I am looking for my eraser. I can't seem to find it. Oh, there it is. Now this is tricky with the data that I've given you. Okay? I just want to qualify this a little bit. This is tricky with the data that I've given you because I've given you the number of people that did not die overall from everybody, because this is not data that we're getting from a cohort study. I've given you only the data for the number of people who have died of breast cancer in this year, in 2014, right? So you can make an argument, well, this isn't really a fair way to calculate case fatality, given that you don't know that all of these 41,211 people all came from this total number. Do you have a question?
Didn't we do something like that? It was like proportionate mortality. So if it's like within a certain year.
Ooh, proportionate mortality is a little bit different.
Okay.
That's actually taking the number of people who died. We did do that. I don't have that plan as a part of the review today, but that's the number of people who died of a particular type of disease divided by the total number of people who died.
Oh, in general, like in that year.
Yes, yes, exactly. In general, in that particular year. Now, sometimes you'll see reports of case fatality rate, in which case they would use the number of new diagnoses. So the number of a particular disease, in which they would use that number as the denominator in that case, just like you pointed out, right? And generally, in that case, it would be called a case fatality rate. Now, I don't want to get too much into this because I didn't make a big distinction between those two, and your text didn't really make a big distinction between those two. What I will do is make it very clear, in cases of case mortality, which of those numbers that you should choose, right? Or think about, well, I can't say too much in terms of exactly what to expect, but be familiar with being able to use case fatalities in order to try to estimate number of lives lost in a particular year. And if you were to compare case fatalities, be able to compare them to be able to calculate how many lives have not been lost due to maybe improvements of treatment, for example. Fantastic. Any other questions before we go on from case fatality? Okay. So I'm going to skip adjustment. We can come back to that. I'm actually prioritizing that lower on what I think that you should prepare for the exam. I did want to get a chance to talk about screening. So I do want to go through that very quickly, but I want to make sure that we get a chance to talk about survival and Kaplan-Meier methods to do survival analysis. So before I get started, how many of you would be available to stay an extra 20 minutes until 12:30 to continue our review? No? All right. Shoot. All right. Well, I want to invite everybody to stay. For those, what I'm going to do right now is very quickly, for those of you who can't stay, read through some of these slides to give you an idea of how you should go through the rest of this to prepare. All right, so do go through screening methods. Remember, the next lecture we had was talking about validation mostly of different screening tests. And I used an example of mammography and some data used to validate those tests right here. Be able to take data like this, right, and be able to fill out a table of true positives, false negatives, and true negatives, right? and use that data to calculate sensitivity, specificity, and positive predictive values, right? And I have those outlined. We have sensitivity, or that's just the true positives divided by the total of people with the disease. Okay. Positive predictive value, that's again true positives divided by the total number of people who tested positive, right? A plus B. All right. And specificity, it's the number of true negatives divided by the number of people who really don't have the disease. All right. One thing I want you to do is make sure that you can calculate that positive predictive value and also calculate prevalence according to different sets of data. I have examples of that data. That's taken from that same validation paper. And what I'd like for you to do is take a look at the relationship between prevalence and positive predictive value, right? The key outcome here is that the higher the prevalence of a particular disease is in a population, the better the positive predictive value is. And that's one of the reasons why if you're going to start a screening program in a particular population, you want to make sure that that disease is prevalent in that population, right? The positive predictive value is going to be better. All right, we'll come back to that. All right. So, remember, we also wanted a way to talk about survival, and that's getting into the natural history of the disease again, which we already talked about, so I will skip right to talking about survival. We talked about measuring 5-year survival, right? So that's the number of individuals surviving 5 years after a diagnosis or commencing treatment, depending on what you're wanting to analyze, divided by the number of individuals alive at the time of diagnosis or the beginning of the treatment, right? Multiplied by 100%. But remember, for certain situations, right, especially if you're going to compare different treatments, right, you might, by just looking at 5-year survival, you might miss improvements of treatments, right, within those 5 years. So the way to be able to still measure those differences is through either life tables or Kaplan-Meier tables. And remember, we focused in on Kaplan-Meier tables because that is generally the preferred method. Right, I'm just going to close this door. All right, so remember, in the Kaplan-Meier method, the event, generally death, defines the time period, right? So for example, and remember this is just an example taken from your text. You have a study with 6 patients. Right? When the first patient dies after 4 months, that defines the first time period. Right? When that second patient is known to be alive for at least 4 months, but they're lost to follow-up. Right? So they're not able to define a time period. Patient 3 dies after 10 months, they define the next time period. So this is a table of that data right here of this graphical representation, right? So we have, after 4 months, 6 people were alive, at which time 1 person died. What I want to do before people will have to leave, just remind you how then you calculate the numbers of cumulative survival or percent survival to put in a Kaplan-Meier graph. All right? And then we'll do that all together. All right, so then the first thing you have to do is take the proportion of people who died, right? So that's just going to be what's in the number of people who died divided by the number of people who are alive, right? And then you have to switch that over to the proportion of people who are still alive, right? So that's just going to be 1 minus the proportion of people who died, right over here. Now, you go ahead and do that for each row. You get the proportion of people who survived at that time, during that defined time period. To get the cumulative survival, or the percent survival, you then have to multiply for each row. You have to then multiply the proportion who survived at that during that particular time period times the people who how much survived in the previous time periods together. So you have to multiply 0.75 times this initial 0.833 to get a cumulative survival of 0.625. And then 0.417 is equal to the proportion who survived at that time, 0.667, times the cumulative survival just before, 0.625. So on and so forth. And of course, if the proportion who survived is 0, then your cumulative survival is going to be 0 by the end. All right. This, then, multiplied by 100% is percent survival. And that is what you would use to put on a Kaplan-Meier graph or plot. Right? Yes?
So on the test, would we be given like a table and then have to calculate those things, or would it be that graph that we saw initially that showed the time they died?
Yeah, great question. So you should be able to fill in the Kaplan-Meier table given you have the number of people who are alive during a particular time period. You would have the time periods and the number of people who died during that time period. And then you should be able to use this information then to calculate the proportion of people who died, proportion of people who survived, and then that cumulative survival. And then you should be able to graph that as well, right? If I provide axes for you, right? All right, this would be percent survival or just cumulative survival. And you should be able to graph that on a graph. All right. So that's what I wanted to make sure I went through with you today. I would like to invite you guys to do a little bit more review practice with going through some of these calculations if you have time. I'm going to just check to make sure we can stay in this room. If we can't, we can go over to 104 and do the rest of the review in there. Just by show of hands, how many of you are able to stay? You can? Okay, all right. And the rest of you, let's see. All right. Yeah.
Can you go over how you calculate the proportion who died at that time?
Absolutely.
I guess if they're like
So, one thing I wanted to do, so I just wanted to make sure I got through the entire review before people had to go. But, let me ask, how do you feel about calculating sensitivity, specificity, and positive predictive value?
Feel good about
Feel good about it? Okay, all right. Then,
I just need to read carefully
how to set it up. Then, okay, then why don't we go ahead and flip to the Kaplan-Meier method and go through that at least. And if you like, what I would like you to do is make sure then, on your own time, go ahead and go through these tables, calculate the prevalence of disease, as well as the positive predictive value for each of these populations. Oh, thank you very much. And see how those compare. All right? And I'll send out something a little bit about that as well. All right, so do make sure you get a chance to do that. Right? The key thing to keep in mind is that as prevalence goes up, positive predictive value will also increase. Right? As prevalence goes up, positive predictive value does as well. Okay. All right. So, I've taken a situation where I sort of have a case here where I want you to pretend you've developed a new chemotherapeutic drug, and it's supposed to help treat triple-negative breast cancer. Okay, so that's breast cancer tumors that don't have estrogen growth receptor, don't have progesterone growth receptor, and they don't have that HER2 epidermal growth receptor as one of the genes or mutations that leads those cells to become cancer cells, right? This type of breast cancer can be very difficult to treat because we can't use some of the other drugs that we know can help target the estrogen, progesterone, or HER2 receptors, right? But hey, you got a new drug. It might work, all right? So what you want to do is try to test that drug in a population of women with triple-negative breast cancer. Now, normally, you're going to want to have, and this is online as well. Yeah, all of this is online. So in this case, you only have 6 people in your study. Now, ideally, you'd want to have more people in your study. But if you're going to do calculations, try to make plots in the period of less than an hour, right, on an exam situation, I'm not going to give you hundreds of people in your study. I'm going to give you something more like this, right? So in this case, we have the time intervals defined by the events here, the deaths, and the number of people who are alive just previous to that death. So what I'd like for you to do now is try going through these calculations yourself and calculate the cumulative survival. Right? So just take a couple of minutes to do that right now, please. And there's 6 of you can pair up as well, if you like.
So just
Yep.
to reiterate, to calculate the proportion of people who died at that time, you take the number of deaths over the people who are alive?
Yes. So column number 4 here, the proportion of people who died at that time are the number of people who died at that time divided by the number of people who were alive just previous to that death. So basically column number 3 divided by column number 2. Does anybody have numbers they'd like to share? They might look a little familiar.
1.6?
Good. 0.25 here. Good.
0.333
Mm-hmm.
and 1.
Yes. Okay, so then the proportion of people who survived is just 1 minus the proportion of people who died at that time.
Point 833. 0.667. 0.
0. Good. So then, proportion of people who survived is 0.833, 0.75, 0.667, and then 0. So now, how do we calculate the cumulative survival?
Start off with a 0.833.
Yeah. So we know survival is 100% to begin, before the study began, right? So it's just 1 times this first proportion who survived, 0.833. Okay, then how about the proportion who cumulative survival after 10 months?
0.833 times 0.75.
Exactly right. Which is equal to
0.625.
0.625. Okay. Now, this table should look a little bit familiar because I actually just erased the numbers from this table that I just showed you, right? So it goes on to be 0.04417 and then 0. Okay. But go ahead and write that down anyway. Okay. Now, I have some new numbers. So, these were the people in the placebo group. Okay? So you want to test this new drug. And you wanted to, in order to test the efficacy of drug, you have to have a group of people who get the drug and a group of people who don't. So you always have to have a placebo group or some kind of control group. This is the survival analysis for that placebo or control group. All right. Now here's the data for the treatment group. These are the people who got the new experimental treatment. You're welcome. Okay. Do they have numbers they'd like to share? First of all, how about the proportion of people who died?
0.1667.
Mm-hmm.
0.12.
Mm-hmm.
1.33 and 0.5.
All right, so then we have 0.167, 0.2, 0.333, and 0.5 for the proportion of people who died at each of the different designated times. And look, these times are different, right? We have someone didn't die until 5 months, first of all, after starting the treatment. And then someone didn't die again until 15 months, 22, and then after 30 months. Right? So new time intervals have to be set for this other group, right? The treatment group. Okay, so what are the proportion of people who survived?
17.
calculate the cumulative survival?
0.833.
Yes. So after 5 months, it's 0.833. And then how about after 15 months?
0.664.
Right. So first, let's talk about the calculations. So it's going to be 0.833 times 0.8. Good. And what do you get?
0.6664.
So 0.666.
Yeah.
6664?
Yeah.
Okay. All right. And then what is the cumulative survival after 22 months?
0.444.
What did you get?
0.444.
And finally, after 30 months? 0.222. All right. Now what I'd like for us to do is, does everybody have these numbers written down? All right. Good. Because I'm going to go ahead and erase them now. And now what I'd like for you to do is make your own Kaplan-Meier plots using this cumulative survival data.